Are you able to see if others are able to join?
We can able to see 41 doctors have joined.
Then why don't we, 41 is reasonable, why don't we start?
Yeah, we can start. Dr. Utumus.
Yes, we can start. I think, good evening, everybody. Let me take this opportunity to welcome all the ENT fraternity to this CME that is sponsored by Microlabs in conjunction with Kent's. Tonight, our speaker is going to be Dr. Mbira Gikonyo. Dr. Mbira Gikonyo is an ENT specialist in Nairobi. He practices in Nairobi Hospital and Gertrude's Hospital. He is also a lecturer at Kenyatta University, Department of Medical Physiology. The session tonight will be moderated by Dr. Edward Mwaringa, who is an ENT specialist in Mombasa, in Pandya Hospital. Dr. Mwaringa is fully in private practice in Mombasa for the last 12 years, but he had also worked for 13 years in government before he moved. Our session tonight is sponsored by Microlabs. Towards the end, we'll give them an opportunity to speak to us. So for now, I want to invite Dr. Mbira Gikonyo to give us the presentation on speech delay in children. Welcome, Dr. Mbira.
Thank you very much indeed, and thank you to all the participants from wherever you are. We're happy to have you join us. And I'll want to quickly go on to the slideshow, and then from there we'll be able now to start on the talk. The challenge of delayed speech development is quite a huge problem, and generally its importance and significance has been increasing with time. And now we get very many parents who end up with a challenge in terms of being able to get their children to talk. I hope, Dr. Otum, that the screen is able to display there. You can see it?
Yes.
Perfect. So we continue. So speech delay is a big problem and generally presents a big dilemma for families. And we first of all start by asking ourselves, what is speech? And speech is verbal spoken production of language, similar to what I'm doing now, speaking something through a language. Another definition of it is expression or the ability to express thoughts and feelings by articulate sounds. Language is regarded as a conceptual processing of communication and including receptive and expressive language. Whereas language is usually thought of as spoken, advocates of visual forms of language widely used by the hard of hearing community are also regarded as valid forms of language, even though they are not actually spoken, but are visualized. Now, the question of what is the prevalence of speech delay in children, there are many, many studies that are done around the world, and generally it's believed to be about 5%. If you go through the literature, you'll find between 2 to 19% is reported. However, the figure of 5% is believed to be what is seen on average around the world. Basic language development takes place principally in the first 5 years of life. And any interventions should also be aimed as early as possible, and certainly within the first 5 years of life. But the earlier, the better in terms of outcomes. Most studies in this field concentrate between the ages of 2 and the ages of 7, as this is usually the time frame for any effective intervention. However, with earlier diagnosis, many children have interventions done as early as 6 months, some even earlier, as that leads to much, much better outcomes. Now, there's an impact to speech delay, and sometimes this is not always clear to laymen, but speech delay affects communication with the child and even with the family and even within the family. A lot of child training, walking, toilet training, feeding, takes place through language. So the moment there's a speech delay or the child cannot understand or hear language, that creates challenges in terms of training the child. The other thing which is most important has to do with child behavior. Many children with speech delay manifest disruptive behavior, and this is often what brings the child to the doctor's attention. Many of these children show anger issues, mainly due to frustration as they are unable to express themselves, and this can really be a huge challenge. Some children end up being punished by their parents or other caregivers because both the parents or the caregivers are frustrated. And of course, if a child is abused or punished, this can lead to psychosocial impairment, and that further compounds the problem that the child already suffers. This even occurs in school. School learning and of course eventual academic achievement is often negatively impacted, mainly because a lot of the school learning is actually done through verbal communication. So the moment that the child is challenged in terms of speech, they're in trouble with the teacher, they are being laughed at by other children, and this affects their self-esteem and eventually their future achievements. All of this leads, you can understand, to behavioral disorders. Attention deficits and behavioral disorders are seen in these children. If a child cannot hear or the child cannot follow speech, they're not going to be paying attention to the people talking to the child. And this creates the attention deficit. And some people take it the child is rude or the child is cheeky or the child is not interested. Most of the childhood behavior is regulated by parental and caretaker verbal instruction. So speech delay impacts on this. Like for many children, you tell them, stop doing that, come here, wait, I'll give you something later. But the moment that cannot be done, that speech cannot be used to regulate behavior, then the child ends up with disordered behavior, and this creates challenges both for the parents and for the child and even for society. The moment the cause of speech delay is identified and addressed where possible, the behavior of these children improves dramatically. There's some children who are very unruly or very distressing to the parents or completely out of control, but the moment they are able to acquire language, you find they change almost completely in terms of their personality and in the interaction with the society. As a result of all this, some children with hearing loss are mistaken to be having autistic spectrum disorders or attention deficit hyperactivity disorders because of that kind of disordered behavior. And this misclassification can lead to clinical mismanagement because the diagnosis has not been made. Generally, if a child gets to the age of above 7 with speech and delayed language problems, then you'll find a number of associated things. Things like poor writing skills, poor spelling, punctuation in language, because they don't understand the language. Therefore, when you tell them there's a pause, they can't follow. So it makes their writing skills get impaired. And then children with what we call developmental speech delay, which we're going to talk about, do better than those with more complex range of language function impairment. Generally, beyond that, there is what we call family and societal impact of the child whose speech is delayed. And this begins principally at the family unit, and it goes beyond the child. Many, especially in Africa, we say a child is brought up by the village. So you find this unwarranted negative attention and criticism from teachers, from neighbors, from relatives, from grandparents. And this can impact the family life adversely because the neighbor asks, what is wrong with your child? The grandparents want to know, how come this child of mine is not talking? What is going on? Are you failing in your parenthood? And this can even lead to maternal depression. In some cases, you can find child abuse, child neglect, or even the opposite, which is too much attention to a child, which is also not good for the child. You can have family relational stresses, which can impact negatively on family life. And even in some cases, you end up with marital breakdown just because a child cannot talk. Eventually, it begins to impact on the rest of the family. And some parents and even some mothers fear having another child because now they look at this child, they see this child has special needs, and they fear to get another child because they fear the same thing may happen. And this even further compounds issues because it is known that having an extra child in the home actually helps the child with a learning disability or a speech problem to actually talk better or learn faster. But now because of that fear, you find now the parents are hesitant to have any other child. Generally, there's a question, do we screen for speech delay? And in general, there's no routine screening for speech delay. Children are attended to when they are presented by the parents. However, screening is indicated for children at high risk for speech and language delay. These children include those who are born preterm, those who have neonatal sepsis, neonatal jaundice, craniofacial malformations, which are often associated with speech problems and hearing loss, and of course, cerebral palsy. These children need to be screened early because they are likely to have either hearing issues or other factors, developmental factors, which can lead to delay in speech. Those exposed to certain medications, medical interventions need to be screened. This includes children taken to their pediatric intensive care units at birth or later in life, children put on aminoglycosides, and those treated for severe infections that include meningitis or even cerebral malaria. These children are likely to end up with either hearing issues or sequelae to the meningitis, and therefore they need to be screened and followed up. Other risk factors, they always say the male child is always at risk for almost every disorder. So even for speech delay, there's a risk. Prematurity is a risk. Low birth weight is a risk. And of course, family history of speech and language disorders is also an important factor. In assessing these children, it's very, very important to have a rough idea of the normal speech developmental milestones. Normally, there are very, very many complex charts which outline all of this. And when you have a child you're examining, it's good to review this so that you're able to see exactly where the child is. Here, I put a very, very summarized kind of, very brief outline that at birth, a child should be able to cry. At 2 to 3 months, they should be able to respond, with a smile or cue. At 6 months, they can babble or turn to new sounds. At 8 months, they should know their name and respond to their name and even recognize themselves in a mirror. At 10 months, they should shout to attract attention or even repeat a syllable repeatedly. 12 months, 1 to 2 words. 17 months, instructions. 18 months, 10 to 20 words. 2 years, 2 to 3 word sentences. 2.5, 450 words. 3 years, storytelling. 4 years, sentence. However, this doesn't occur exactly like that for many children. Some children, especially those with the siblings who are about their age, tend to talk much, much faster, while others, like a firstborn, may tend to delay, sometimes due to lack of stimulation in the family. But generally, it's always good to have an idea so that if a parent comes to complain their child is not talking, you can look at the age of the child and then you see whether at that age they should be able to give the kind of speech that the mother or the parents are trying to talk about. Now, there are many, many causes of speech delay. Some of them we may have to look at another time, like developmental speech and language disorders, and where a child has difficulty using or understanding language. And that's a complex area, but we'll try and have another session maybe in a week or two where we get speech therapists to talk to us about language and speech pathology, which can explain some of these disorders. Hearing loss is, of course, very, very important in ear, nose, and throat surgery and field. And the goodness of it is the hearing loss is often treatable or can be managed or can be rehabilitated. So that's a very, very important point at which you can actually intervene. And then there's something we call extreme environmental deprivation, which can cause speech delay. Child is neglected, child is abused, or does not hear others speaking, and therefore they never learn how to speak. This problem is actually fairly common in the modern society because many parents, both the father and the child, they leave very early to go to work in a place like Nairobi, and they come back quite late. So they are not with the child for more than 12, 14 hours. The child is left with a maid. And sometimes that maid is instructed, make sure the house is clean, make sure the food is cooked. So other things are emphasized. So when the child is left with the house help, they're totally ignored. Nobody talks to the child, nobody stimulates the child. So at the end, the child withdraws into themselves and never learns how to talk because nobody ever talks to the child, nobody stimulates them. And that can be a real issue. You can do all manner of tests and you find the child is perfectly normal, but the problem is in the home environment. So you always have to take an interest to know how is the child looked after at home. Things like prematurity can lead to speech and language problems, auditory processing disorders, where decoding of speech sounds is an issue for some children. And then neurodevelopmental disorders are increasingly important: cerebral palsy, muscular dystrophy, traumatic brain injuries, sometimes during birth. All those can affect the muscles needed for speaking. And then nowadays you have perverse developmental disorders, and they appear to be really, on the upswing and are very common. And all these do impact children, considerably. Autism is one of those things that is very, very big nowadays. Autism, like 20, 30 years ago, used to be one child in about 200,000 children. And now it is one child in 50 has autistic tendencies. In a place like America, some studies even claim it's much higher than that, even up to 1 in 11, according to a published study. So there's a problem there in terms of autistic disorders and hyperactivity disorders that are now increasingly very, very common. Before, it would take many, many months before we'd see a child with autism. But nowadays, if you run a radiology clinic, you'll find several children every time you actually run a clinic. And you'll even find one mother, a young mother in her 20s with a young father in his 20s, but they have got 2 children who are both autistic, extreme autism. And it's a pity, but it's becoming increasingly common and is very, very challenging in this area. Of course, there's apraxia of speech, which sometimes we call functional, a functional disorder, meaning, a child has difficulty sequencing or like executing speech movements in certain, environments sometimes. Selective mutism, sometimes in school, the child doesn't talk, but when they come home, they talk. So all these are part of the causes of speech delay. Then, of course, us in medicine, we like to intervene. We like to see what can we actually do about these disorders. What is our role, especially as ENT people? And our role, of course, is diagnosis and diagnostic. Now, no newborn hearing screening should be done for all children after birth and before leaving hospital, and whatever the case, before the age of 6 months. Unfortunately, in Africa and many other countries around the world, this is not done. And though there are some programs locally which seek to start this, it is still not prevalent. But until this is done, we shall keep on missing children born with hearing loss. So once it is clear there's a delay or disorder in speech and language development, specialist referrals should be done to the ENT surgeon, to the hearing, for hearing assessment, to an audiologist or speech language pathologist. And this is very, very important. Unfortunately, for many, many years, we didn't train locally speech therapists or language pathologists. And this has impacted our ability to actually deliver care to these children because they should be there. There you find ENT doctors all over the country, neurosurgeons all over the country, physicians all over the country. They should have had these people available in every town because that is what we actually need. But now colleges are beginning to offer that course. So speech and language therapy is normally required in the rehabilitation of these children. So that's why it's very, very important to have people who are trained in that field and who are dedicated to helping these children, regain language. Assessment and early intervention is certainly way better than watchful waiting approach, and normally is the best predicator of good language, outcome. The challenge is that if you keep on waiting and say, for example, the child has a hearing loss, you're not going to get to a day when the child will talk. So you need to know what is wrong. And then once you know what is wrong, seek to rectify the problem, because that is what will help these children. Of course, hearing loss is the commonest treatable cause of speech delay in children. And of course, we know our standard otitis media diffusion and that it can cause mild to moderate hearing loss. And in some children, that is sufficient to delay speech. We once treated a child who was 4.5 years old who had come in from Denmark. The parents were diplomats in Kenya. And this child, they had been told in their own country, this child was severely autistic. And the child was very violent. To even examine the child was literally almost impossible. We had to hold him with the dad and the mom and somebody else. And he was quite a fighter. But when we examined the child and did some tests, we found he actually had otitis media diffusion. And after much debate with the parents, the father was very hesitant, the mother was interested. They agreed for us to do a meningotomy plus grommets. And within 3 months, this child actually began to talk. Within 6 months, he could talk grammatical English. Within a year, he had perfect language. So you can see sometimes something as small as what appears to be small moderate hearing loss due to fluid in the middle ear can actually cause speech delay and can even cause a child to be labeled as autistic, as opposed to being treated. So always look out for these things and seek to treat them. And they can make a big difference in the life of a child. Things like, separated from otitis media, these are not very critical very early in life and usually don't contribute a lot to speech delay. But when they do occur, they need to be paid attention to, and they should be treated, early so that, the impact on a child is not too bad. There's some children who can even end up with speech regression because they are hearing well. They began talking, but now the hearing is impaired and they begin losing their speech. So this is important to take an interest in. Sensorineural hearing loss is very, very important. Up to 5 children out of 1,000 are born with congenital sensorineural hearing loss. Some are syndromic, and there are all manner of syndromes, which I've listed there, which can cause this kind of hearing loss. And of course, that needs to be looked into. The other source of sensorineural hearing loss, of course, we know is ototoxicity and infections. Increasingly, this is not as bad as it was 20 years ago when we had a lot of malaria, quinine, ototoxicity, and even aminoglycoside ototoxicity from pneumonia and meningitis treatment. Increasingly, this is not as widespread as it used to be, but still, exists, and still we have to take note of it. And then there are others, what we call auditory processing disorders, central auditory processing disorders, which can actually cause problems because the children, in this case, don't hear the way other children do. And because their ears and the brain don't fully coordinate language and words. And the speech pathologists can talk about that and tell us how they normally handle that. Generally, we are, of course, in otolaryngology, and so we want to see what is the standard approach if such a child comes to you. The standard approach in medicine never changes. History remains the single most important thing. Examination, again, physical examination is extremely important. And between history and physical examination, you often can actually make your diagnosis. And you only do the basic tests and investigations to confirm your impression, which tends to be correct. From there, you get your diagnosis, and then you manage the patient, and then you follow up on the patient. But history is key. In fact, if you take your history properly, you'll actually get the exact problem. A properly taken history can give you the diagnosis. If you ignore history, you ignore it at your own peril because you not know what you're dealing with. For example, the classical history of malaria, cerebral malaria, or meningitis, followed by hearing loss, speech regression, that is clear-cut sensorineural hearing loss due to toxicity or meningitic sequelae. So just from the history alone, you already have a very good idea what is happening to the child. Of course, perinatal asphyxia, admission to ICU, delayed developmental milestones, cerebral palsy, or other developmental challenges. So this again gives you a very good idea as to what is happening to that child, and even know how to counsel the patients and the parents around that issue. And then we normally have standard questionnaires, and very many of them are available online. And these questionnaires, if you actually administer them, then you find, even before the person comes into you, they come to the fill out questionnaire, you can actually figure out what exactly is happening. And then you have to interview the parent or the guardian who's the primary caregiver. If possible, whether housemaid or dedicated caregiver is available, they should be interviewed to answer some of the questions, because sometimes some parents are not available due to work for their children. Therefore, you need this kind of input from the person taking care of the child. Of course, things like illnesses during pregnancy, German measles, rubella, CMV, all those can contribute to congenital, hearing losses. So that's very, very important for you to actually know. Of course, you have to know, what the child born at the right time. Did the child cry immediately after birth? If the APGAR score is available, they should tell you. milestones, at what age do they see it? What age do they start, walking? Generally milestones give you an idea of the neurodevelopmental development. And of course, if all those are normal, yes, the child cannot talk. That's what tells you that the brain may not be the issue, that it may be something else. And then one of the most critical things, does the child know his or her name? All these kind of questions are very, very important. But after working in this field for more than 25 years, there's what we call the most important question. And this question is a question of the child's name. Does the child know their name? It's a very, very simple question, but it's a very, very important question. Of course, you should also know by what name they call the child. The child may be called Jeffrey, but maybe they call the child Jeff, or they call the child Daddy, or something else. So you need to know what do they actually call the child, and you yourself should attempt to call that child. And then you find out, do they use that name, all the time? If a child doesn't know their name, by the age of 1, even worse, by the age of 3, and does not respond to it, then that's a fairly serious problem. And generally, in such a case, the only things which can cause that is severe performance and sensory hearing loss, meaning the child actually cannot hear. Another cause is, of course, autism or autistic spectrum disorders, or things like cerebral palsy or other pervasive developmental disorders. Of course, if a child has cerebral palsy or developmental disorders, even looking at the child, you can immediately see, the child maybe can't see it, can't walk, is impaired physically. But of course, since when you're hearing loss, you can't know by just looking at the child. But at least this gives you an idea that the child doesn't know their name. That's a serious issue there, which requires attention. The child must know their name before the age of 1. So of course, autism is now a very famous diagnosis alongside attention deficit hyperactivity disorders, mainly because of rising incidences in Western Europe, worst is in America, and now even in Africa. And now many parents come very worried that maybe their children are autistic. And because of the internet, they read about it and they come with very many questions. Now, one of the interesting things that you have to do in audiology is to ask about the home environment, because the environment in which a child is growing can influence the development of speech. And that is very, very important. What language is used at home? Sometimes you find a mother employs a housemaid. Say, for example, she employs a housemaid who talks Luya and Kiswahili. But the mother wants a child to learn only English. And she tells the maid, talk to this child in English. If you can't talk in English, don't talk to my child. So at the end, the maid ignores the child, yet the maid is a person with the child the whole day. So nobody's talking to this child at home, and that can create issues. So you have to find out what is the language spoken by the caretaker. What is the home environment like? Are there other siblings? What is the age of the other siblings? Are there any other challenges in the other siblings? If the other children of about the same age with this child, and the child is not talking, then that tells you it's a more serious issue. But if it's a one single child, the only child, no other children in the house, sometimes it's just how they're handling the child that may be contributing to this kind of thing. So that family environment is very, very important. Then relationship between the mother and the child. There's some children who don't know who is their mother, between the mother and the maid, because the mother is very, very busy. It's a modern world. So again, those relationships can create some kind of distresses in your child. And then you find the child is manifesting that by not talking, even when they are completely normal. Of course, after the history, you have to do a physical exam. And again, this is important. Some of these children are not easy to examine. They scream, they yell, they can bite you, they can kick you, and sometimes you need to restrain them. So, but you still need to, but generally take your time, look at the child. From the moment the child takes in, try and observe the child, are they hyperactive? Are they restless? Are they able to take verbal commands? How is the parents handling the child? Are they holding the child's hand because the child will take off? All these are very, very important. Do they appear normal? Do they appear syndromic? What are the neurodevelopmental milestones? If a child is 1 year, they can't hold their neck, or they're 2 years, they can't walk. This, of course, tells you that there are some challenges, in terms of the brain in such cases. Then you look at their behavior. Is a child disruptive in the time they are there in your office or in the clinic? Are they throwing things on the ground? Are they screaming? Are they yelling? Do they listen to the parents trying to tell them, stop doing this? Are they able to hear the parent? So just your own observations make a tremendous difference, and it can actually be able to enable you to actually tell what may be happening. And then, in your own opinion, do you think the child is hearing? And then you also ask the parents for their opinion. Does the child hear according to them? And that's always a good and a useful question to actually pose. And then, of course, normal standard examination, try and see if the child make any eye contacts. Is the child cooperative? Do they trust the parents? Are they disruptive? Are they disconnected from those around them? Of course, you have to look at the ear canal, tympanic membrane. Sometimes they have atresia. They have wax, tympanic membrane, and they have fluid bubbles. Is it OME? So all those are very, very important. And then once you finish the physical examination, sometimes you have your diagnosis. You might find it's glue ear. You might find a child has atresia. There are one of things you may actually find there. And that, again, may give you a diagnosis. But of course, often, even if the examination may be completely normal, and still you want to confirm whatever you suspect, and therefore you go on to investigations. Sometimes you can have some toys, what they call distraction tests, which somebody behind the child can actually make some noise, and you see the child actually looks. And then, of course, you'll attempt to communicate with the child. Get somebody to call the child's name and see if the child turns. And then, of course, the idea for ENTs to establish is a hearing loss, because even a mild to moderate hearing loss can actually cause speech delay. The goal is always to make a diagnosis. You do some basic tests, what you call acoustic emissions, tympanometry, ABR, ASSR. Sometimes you can do X-rays. If you feel, or CT scans, we feel that they are necessary to even, certain parameters you will be looking at. Sometimes genetic studies, need to be done for syndromic children. So all those investigations are done. But because investigations are expensive, you tailor an investigation depending on the direction in which you think the diagnosis actually lies. Of course, you aim to make a diagnosis. Things like conductive hearing loss, you address it. If it's wax, you remove it. If it's otitis media diffusion, you give treatment, medical treatment. If it's failing, you do an operation. With atresia, you can even fit what we call a bone conductor, which can enable the child learn how to talk before such time as when an operation can be done. Sensorineural hearing loss, you can have hearing aids or cochlear implants. So once you have your diagnosis, you can actually begin to intervene in a manner that helps the child. Because the sooner the intervention is done and the earlier, the more better the prospects of the child actually talking and gaining normal language. So you don't want to delay. Even if you plan to do a cochlear implant, but you're not able to do it now, you can start with hearing aids. And then one day a cochlear implant can actually be done. So you need to intervene so that you actually start helping the child. Things like attention deficit hyperactivity disorder, they can go for speech therapy, they can go for physical therapy, they can go for occupational therapy, and this actually helps improve their ability to attend attention and therefore eventually gain language. Autistic spectrum disorder, this needs to be sent to a neurologist. They administer some questionnaires and they come to a conclusion, and they have certain interventions that they can actually go ahead and recommend to the parents. Then the perverse developmental disorders, again, this need to be diagnosed, the parents counseled, and interventions actually put in place to try and address these particular goals. I just want to share with you a bit of some of my own data from my own clinic over the years. And I want to compare 1994 to the year 2000 and the year 2011 to 2016. Normal hearing of the children who are sent to us for testing. How many had normal hearing? You can see 20 years ago, 1994, only about 10% had normal hearing. Nowadays, up to 60% of the children sent to us have completely normal hearing. How many have conductive hearing loss? At that time, and even now, about 20% had conductive hearing loss of the children who are sent to us. How many had sensorineural hearing loss, mild to moderate? 10% had that in 1994. And by 2011, there were still about 10% who had that. But way back in 1994 to the year 2000, sensorineural hearing loss, severe to profound, or more than 70 dB, up to half of the children we saw actually had sensorineural hearing loss, about 70 dB. Nowadays, only about 10%. So many of the children who come to us now actually have normal hearing. And part of the reason is that nowadays we increasingly see children with autistic tendencies. In those days, barely 5% of the children who came to us had what appeared to be autistic tendencies. Nowadays, up to 50% confirmed by their pediatricians. So there's a change there. Then in those days, attention deficit is about 5%. Nowadays, it's about 10%. So you can see increasingly, many of the children seeking help have actually normal hearing, but they now have neurodevelopmental, disorders. Of course, we might say maybe people are more prosperous and therefore they're able to seek medical intervention earlier. Maybe that's the difference. But that just shows you that increasingly children with normal hearing are actually being assessed for delayed speech as opposed to the past when you used to see people post-meningitic and post cerebral malaria. So the future trends generally, of course, around the world and even in Kenya, that adenoids, tonsil, asthma, OMEs, allergic illnesses are increasing due to pollution. And of course, that would mean that the middle ear disorders due to tetrasmedia diffusion, those who tend to be up there. Neurodevelopmental disorders, autistic spectrum disorder, attention deficit, hyperactivity disorder, are really a very, very big issue. Even when we get doctors from the US talking, to us, they often mention that, attention deficit is so common now in the US that almost every neighborhood actually has children with that kind of disorder. So it's not clear whether there's overdiagnosis or other factors at play, but certainly, even if you talk to any pediatric neurologist, they tell you they diagnose a lot more than they used to do in the past, and it's not clear exactly why. Generally, we are seeing less of severe sensorineural hearing loss, mainly because there's less ototoxicity from malaria and meningitis treatment. Malaria, of course, incidence and prevalence has gone down. Even if you go to Kilifi, Malindi, or Kisumu, you'll not find a ward full of children with malaria like you used to find in the past. And therefore, it means that you're not going to have the toxicity levels that you used to have 20 years ago. But generally, what it means is that the need for speech therapy, language therapy, occupational therapy is increasing because there are many more children with the spectrums, developmental spectrums, autism and attention deficit, which brings us to the idea of and the concept of speech and language therapy, because this is critical in the management of delayed speech in children. Because even if you put a hearing aid on a child or you put a cochlear implant, you still will need to have speech therapy with these children. Of course, I've mentioned speech therapists are few and far between in our country, though now they're being trained. But what we want to do, we want to have a special session, maybe next week if the group allows, to have a specific presentation on the current concepts, speech and language pathologies, new ideas, rehabilitation, maybe as early as Thursday next week, so that speech therapists can come and talk to us about what are the current trends, what are the current thinking, how they're rehabilitating these children, because even after the surgeries or after the cochlear implants and after the interventions, some of these children are still challenged in terms of language and speech, and they need the speech therapy. Others, of course, they need speech therapy because what they have cannot actually be solved in terms of a surgical or even medical intervention. Over and above that, I'll just mention in closing the basic tests which we normally do. Each part of the ear can be tested, of course. About threshold, involves the whole ear, like audiometry. About impedance, the middle ear compliance, autoacoustic emissions. So I'll just mention a few. The important ones are autoacoustic emissions, which is what we use for pediatric newborn screening and early first year of life screening. There's the autoacoustic brainstem response audiometry, which is what measures the whole pathway, hearing pathway, and determines for us the thresholds. And then there's another one known as ASSR, acoustic steady state response audiometry, which is not very popular because it has some challenges, but those are the main tests which are carried out. Of course, I'll not go too much into the details because you're familiar with them, that you can identify if there's a hearing loss. It's good for newborns, an assessment of small children. And it looks at the integrity of cochlear function. It can also be used for ototoxic treatment, monitoring, even noise exposure, because the autoacoustic emissions are able to show you somebody who is actually losing their hearing from noise exposure before you can see it on audiometry. And of course, it also useful for differential diagnosis for cochlear and retrocochlear pathologies. I'm not going into details of this. This is what we call transient evoked acoustic emissions, distortion product, spontaneous. All these are technicalities. The important thing is you carry out the measurement, and then you see, does the child, pass or fail? Now, There's what we call tympanometry. Tympanometry, of course, measures the middle ear, and this you must do if you're going to do autoacoustic emissions, because the middle ear must be very, very clear in terms of, no wax, no fluid for you to get proper autoacoustic emissions. This is just a small diagram trying to illustrate how you send the sound there and how it actually comes back, which is then measured. And they're very sensitive to middle ear, disorders. Again, I'll not go into much detail here unless a question comes up. Brainstem, response audiometry is an important one, looking at the whole neuronal function. We generally have to connect a child like that, like in that picture, to a computer to carry out the measurement. And for children above 1 year, you need sedation because they sometimes do not naturally sleep, and sedation can create a number of challenges. This is just a diagram to illustrate. You have a transducer, you have stimulus, and you have a computer to actually measure and get certain waves. And you can get up to 7 waves. The most important waves in audiology is the wave 5, because it's the one which is most reproducible and found in most cases, and therefore that's what we normally use for the diagnosis. Of course, all these waves come from certain parts. Wave 1, cochlear, nucleus, wave 2, and so on, until the auditory radiation. And sometimes you can study these to be able to see the whole auditory pathway, in your assessment when it's necessary. And then this is an example of a normal one, where you've got reproducibility from 90 dB up to 20 dB. This would be normal. And then, the machines nowadays give you normative data, so they can show you everything is normal in this case. They can show you there's an airborne gap, they can show you in case of severe, profound. So, there are all manner of things you can actually do. I'm not going into details of this because what I want to do is just have a quick overview of the various ways that one can actually assess. But ABR remains the gold standard in terms of that kind of audiological measurements. And to save on time, I'm not going to ASSR because it has a few controversies. I'll only mention that ASSR is actually able to measure for you up to 120 decibels, whereas ABR usually goes just about up to 90 decibels. So ASSR is preferred if you want to really see how severe the hearing loss is. But generally, if you have a severe hearing loss is above 90, you obviously will not hear anybody talking to you, and that is severe to profound, and that will require a cochlear implant or a very powerful hearing aid. So that's why even if you just measure up to 90 and you're satisfied your hearing is above 90 dB, then hearing loss above 90 dB, then the intervention doesn't really change. Now, of course, there are problems when you try and sedate children. In the past, for more than 25 years, we used chlorohydrate for sedation of children. It was regarded to be very, very safe. But nowadays, standards have changed. And in many hospitals in the Western world, even in Kenya, they've banned chlorohydrate. They say that it has a number of issues. Sometimes even after the child has gone home, they can still, fall as they run around. So in most of the hospitals that we've operated on, including Gatwick Hospital, chlorohydrate was banned. Also in Western Europe, nowadays is increasingly difficult to get. So nowadays we are unable to use that. If you use any other sedatives, they are always in danger of respiratory depression, and that can be very, very serious. Of course, by anesthetics, you require an anesthetist. Generally, if for any reason you decide you're going to sedate a child, you must follow the institutional protocols. Otherwise, you'll be in trouble with the hospital. And there must be a nurse present with the child all the time. There must be a physician or anesthetist in the area who can resuscitate the child. You have to monitor heart rate, oxygen levels, blood pressure. You have to have a, crash cart, oxygen sanction available, because even something going wrong with one child can create huge, huge problems. So nowadays, if you sedate a child, you must monitor. That's a minimum, and you must be ready with an emergency tray to resuscitate that child. So it's better sometimes not to sedate them. And if you do, then you take all the precautions. Obviously, going to theater for ABR is not advisable because it's very, very expensive. You can see all these guys reading newspapers there. Just when one person is carrying an ABR, so it's a very expensive thing going to theater because you need, security nurses, you need the person doing the test. So and of course, the hospital will charge you, and I'm gonna like to occupy their space like that. So generally, we avoid that. One, due to expense, and then it's not so convenient, to do that. But in conclusion, early diagnosis, appropriate and early intervention, whether it's surgical, hearing aids, cochlear implant, counseling, or even a change of a maid sometimes. Sometimes the birth of another child can stimulate speech in a language. Childhood hearing loss, we normally aim for normal speech and normal language development. I think I'll stop there for now and hand back to Dr. Otum and Dr. Mwaringa. I hope you can hear me.
Yes, loud and clear.
Yes.
Thank you so much, Dr. Mbira, for that very informative discussion on delayed speech in children. I now want to invite my senior colleague, Dr. Mwalinga, to take us through the next session, which is the question and answer session. Welcome, Dr. Mwalinga.
Thank you very much, Dr. Otum. First of all, I also like to thank Dr. Mbira for this wonderful presentation. There are a number of questions that have been posted, so I think I'll read the first one. Helen Otunga is asking, kindly comment on excessive exposure to electronic devices as a cause of delayed speech and language.
That's an area of great concern because very many children actually right now are addicted to smartphones and to all manner of gadgets, mainly because parents actually give it to them very early in life. And there are many, many children who, when they come to the clinic, the only way to make the child cooperate for an examination or to do anything, they have to be given the phone. And generally what is believed is that the centers for addiction, whether you're taking alcohol or cigarette or drugs or using a phone, they're the same actually. And therefore they may be a very serious implication in future so that they may begin with the addiction to the smartphone when they're young, but eventually may even end up with things like drugs. But over and above that, there are very many children who, when they get used to electronics, they develop a certain pattern in their mind that they think even people are like electronics. They think you don't need to interact with the parent. You don't need to interact with your brother. They're like people on a screen. So that creates confusion in some children and can cause them to turn inwards. And therefore, if they have an autistic tendency, it worsens the autistic tendency. In fact, any child with an autistic tendency, the parents are always told, stop any electronic devices given to the child. So the child is forced to interact with real human beings. So that is a real concern, and parents have to learn to make time to interact with the child, because there are very many children now we see whose problem is that nobody talks to them, nobody interacts with them, nobody plays with them. Therefore, they have no interaction with the real person. They interact with cartoons and with YouTube. And so it's a big concern, and it's believed in future it'll create even new and bigger problems than we've had.
Thank you, Dr. Mbira, for that. I hope Helen has heard you out and loud and clear. The second question is from Rotich C. Gladys. The question goes like this: autism cases are alarming. Might environmental factors be an issue? I see more clients in Nairobi town setup, in Nairobi's town setup than in rural areas. Any latest research?
Autism is a big challenge, and what you say about Nairobi, is true. But even asthma is more in Nairobi. You'll find, the adenoids and the tonsils, and all these allergic problems are more in Nairobi because the cities have certain peculiarities which tend to bring out these things. Like cities are more polluted. But when it comes to autism, the real reason or cause is not clear. Mainly because whenever we say I've got more cases of autism in Nairobi, if you go to Europe, there are more than here. If you go to North America, in fact, in the US, there's actually an epidemic of autism, and it's not clear what is causing it. But generally, when you look at a child, if you think about asthma, you think of tonsils, adenoids, and allergic conditions, it's because the air is polluted. And as the air goes through the nose, through the mouth, and to the chest, you can see why it's going to bring a problem. And then if you look at things like obesity, again, that may be the food factor. Like in America, the fast foods, even in Kenya, the kind of foods now we feed children, that would certainly be a factor. In other words, what have they taken? But when it comes to autism, because it's a neurodevelopmental disorder, it's not always obvious. exactly what is happening, because it's not something they're breathing, it's something they're taking. People speculate it's something they're being injected with, but there's a mystery there, and a lot of the research goes on in America, but they claim they don't know. You know, so because we tend to follow the Americans, we also claim we don't know. But certainly the cases have increased. If you talk to any pediatric neurologist, any pediatrician, anybody dealing with children, there's certainly a huge problem there, and it'll continue to increase. Yeah, but it's not clear why it is happening. Yeah.
Okay, thank you. I hope Gladys has also heard that. The next question is from Dr. Nyaga, Samuel Nyaga. First of all, he says, thank you for a good presentation. Now the question is, can you have an isolated failure to develop speech? This is to say, without any other neurodevelopmental or hearing issues?
Yes, indeed. And there are many children like that. There are many children who we test, and you find all the parameters are normal. The hearing is normal, the home environment is good, the other children there who actually talk fairly well, and nobody can quite explain. Yeah, so those kind of challenges are there. And but generally, many of those kind of children can actually be stimulated to talk through speech therapy, occupational therapy, and some may take time. Like there's a friend of mine who had a child like that, but the child began talking at 10 years and actually went on to finish university. So sometimes there are those kind of challenges. But the idea with a child, especially, is never to give up. You know, tell the parents never to give up, to keep on working at the child, to always believe the child will talk. I find what the family believes tends to be what eventually happens, especially when everything else is normal.
Thank you for that. Boaz Nyakwara says, good evening, panelists. And then the question is ADHD a disease of childhood, or what is the prognosis for such children? I have not encountered adult patients with such a problem in my practice. So what's your response to that, Dr. Mbira?
You know, attention deficit hyperactivity disorders are there even in adults. It's only that as somebody grows up over the years, they learn how to control it. But in a place like America, there are children who are diagnosed with it, they eventually grow into adults, and they still have a bit of hyperactivity and attention deficit. So it is there even in adults. But with time, somebody can be trained to concentrate, to pay attention. And therefore, with time, they're actually able to control those aspects of hyperactivity or attention deficit. But certainly it's there. But the important thing is to work with those children, because especially once you have language, then you can use language to insist they pay attention, to insist they behave in a particular manner. And then they can learn or train themselves to overcome their attention deficit and to pay attention and to continue with a fairly normal life.
Thank you. Jacob Mwirigi is asking, kindly comment on tongue tie in relation to delayed speech, development.
Very severe tongue tie may create issues with feeding and may create issues with speech, but the kind of speech issue it will create is in terms of pronunciation, because sometimes the child is not able to move the tongue adequately. But it's not a huge contributor in terms of delayed speech. Yeah, as such. It may cause mispronunciation, but a child will certainly talk even with the tongue tie. But if it is obstructive or it creates issues, it can be loosened. But that normally doesn't stop a child. You don't find a child who cannot say anything just because of a tongue tie. No, they will talk but mispronounce words, and therefore, the moment you release the tongue, then they are able to do it better.
Thank you. The next question is from Serandegwa. She said, thank you for a good presentation. You have highlighted the importance of early diagnosis and intervention of hearing loss. Kindly comment on the issue of neuroplasticity as one of the reasons why hearing loss, particularly severe to profound sensorineural hearing loss, should be treated at the earliest possible for good outcomes of speech and language.
Yeah, neuroplasticity is extremely important in children, but even more important is the idea of stimulation. If you've got any part of the body or any neural path which is not stimulated in childhood, it tends to actually be lost. They even say in ophthalmology, if you took a young child of 2 weeks old and you block their eyes or even one eye for 2 weeks, they become neurologically blind. That I can no longer see because it's like the body shuts down those neural pathways and the parts of the brain dedicated, say, to speech and to hearing if there's no stimulation. Therefore, early stimulation is critical, which is why we need as early as possible for the intervention to be done. Because if a child cannot hear, it's better you put that hearing aid, they start hearing. Even though it's not adequate, at least there's some stimulation. Because that stimulation is what causes the auditory pathways to grow, and therefore that neuroplasticity and that bandwidth or brain power dedicated to hearing is preserved. Yeah, when you come in very late, there are many children you're actually not able to intervene. But in Africa, we tend to be late, mainly because we don't screen the children early enough. When we start screening early enough, then we can intervene early. But early intervention is a most beneficial way of actually ensuring speech and language development takes place. If you don't intervene early, you'll always have issues and you'll always have problems, and you'll find that some children, no matter what you do, you're not able to gain as much. But when the younger they are, the better the outcomes. Yeah, it's a bit like the stem cells. Before they've dedicated themselves to certain functions, if you catch them early, then you can make them dedicate themselves to whatever you want them to. So it's the same kind of principles. But in hearing, early intervention is the biggest benefit you can give a child.
Thank you. There's a question, but I don't know who posted it. But the question goes, thank you for a good presentation. What can be done to a 2-year-old who does not speak but follows all instructions and can hear very well?
Normally, that's a bit of a challenge, but normally we look at two things. Number one, is it the only child at home? If they're the only child at home, you have a bit of a challenge because sometimes some children believe talking is for adults. So it's a psychological issue as opposed to a real physical issue. And in such cases, we normally recommend speech therapy, if you're able to take a child for speech therapy, or even get the child to school. When they go to school and meet other children who are talking, who beat them up because they cannot talk, they stimulate them into talking. So the idea is to stimulate a child. If a child is completely normal, try and get them to school. School is a form of therapy by itself because you come across another crowd there doing certain things. So you learn to do things with others, especially for children who are alone. And unfortunately, increasingly, families are very small. Children are very, are sometimes 1 or 2. And sometimes the spacing between a child, if one child is 10 years old, another one has just been born, it means the older child is barely available to help stimulate the younger child. So you try and stimulate them. In fact, in pediatric audiology, we normally say whatever works. Yeah? School, speech therapy, whatever will work. But don't give up on a child. Keep on working at it. Try different things. And then eventually they'll talk. But normally if they can follow all the instructions, they will talk. It's a matter of time.
Thank you very much. Martin Maura is asking, okay, first of all, he says, good evening, panelists. Thank you so much for a wonderful presentation. His question is, can delayed speech be passed down generations? Is there genetic involvement?
That is a good question. Generally, many disorders do run, genetically. In fact, the Bible calls it the sins of the fathers punished upon the children. So you'll find there are speech disorders in certain families, there are pronunciation issues, and even the up country, they'll tell you, oh, in our family, people talk late. So they are there. But as a caregiver or even as a parent, you have to always try and get your child to be as normal as possible. So that if they are learning, if they are late, you try and get them to be stimulated through speech therapy or through school or through assessment. So don't just sit back. Because what is bad is to sit back and then there's a problem which could have been solved, but which gets ignored.
Thank you, Dr. Mwaringa.
Yes,
Dr. Dean wants to make a comment. Maybe we can allow him at this stage to make a comment.
Sure. In fact, I was going to allow him. To do that. Dr. Dean, please go ahead.
Hi, Dr. Mwaringa. How are you doing?
I'm good, and you?
Thank you very much. I'm fine. I had a couple of comments. First of all, thanks to Mbira for raising attention to this very important topic. My two comments, one are both on the surgical interventions for delayed speech. And the first one is on the issue of myringotomy and grommet insertion, which much before the COVID epidemic, and I referred to this in our last conference, I've seen that there's been an epidemic of myringotomy and grommet insertions in Nairobi. And many times, and on more than several occasions, patients have come for second opinion to me, and they said that so the doctor said I have water in my ear, and I need a myringotomy and grommet. So I said, okay, fine. Can you show me audiogram? I said, and they asked me, audio what? What I'm trying to bring attention to is that for prescribing myringotomy and grommet insertion, there are some basic essential investigations that must be done. Okay, fine. If you diagnose speech delay, there must at least be an audiogram. And the guidelines, I believe, are that it should be at least 30 dB. There should be a 30 dB airborne gap. And the tympanometry should agree that there is some fluid in the ear. And furthermore, there should be failure of conservative treatment. Sometimes the fluid can be temporary. If all these three conditions are met, then one is justified in prescribing a myringotomy and grommet insertion. The second one is a very quick one, and Mbira referred to this, but I wanted to make it clear in terms of in a young child, if you diagnosed hearing loss, especially if it's congenital, yes, if it is up to moderate and maybe some severe cases, you can do a trial of hearing aids. But I think our listeners will probably agree with me that if it is profound, then there is very little evidence that hearing aids help. In that case, the patient should be considered if the other criteria are met for cochlear implantation rather than lose time. Because in cochlear implantation, earlier the intervention, the better. Thank you very much for your attention.
You're welcome. Thank you, Dr. Dean, for your comments. Shall I proceed to to present Florence Luganje's question? First of all, she starts off by saying early intervention through screening is key to management. As a country, we need to make infant screening mandatory. What is your take?
Yeah, generally, hearing screening should be mandatory as much as possible, but still you cannot mandate something for which the equipment is not there and the hospitals are not able to give it. But that is the only way. Children should be caught as early as possible, as Dr. Dean, emphasized, and even Serandegwa, because that is the best way to get the best possible outcome. When children come at 2.5, some even come at 4 years, you've lost a lot of time and you're running out of time. So as much as possible, we should push for that, so that if possible, all the level 6 hospitals and level 5s and level 4s even should have the screening, and that can make the biggest difference.
Okay, thank you. It looks like Joseph Ayeko has made a follow-up of what Florence Luganje has asked, because what he says is, what could be done at a police level to roll out early hearing screening or capture the population in the rural country setup? He says this was a very good presentation, Dr. That is from Dr. Gikonyo.
Yeah, I think if you can open up for Professor Macharia, he's done quite a bit of work on the policy issues around early childhood, and maybe he can make a comment. Are you able to open his mic, Professor Macharia? Professor Isaac Macharia.
Okay.
Yeah.
Prof. Macharia, can you hear me?
Hello. Yes, I can hear you.
Good.
Yes.
Good. Hi.
Sorry, can you hear me? Because I have some very unsteady internet.
Okay.
And I just heard about the question on what can be done when you look at the national plan.
Yes.
The national plan for hearing, one of the major pillars is neonatal screening. And of course, for neonatal screening to become universal, you need to have testing, you need to have the infrastructure. But crucially, testing is not actually one of the biggest problems. One of the biggest problems is that if you screen, you need to offer a service. And that service includes how do you carry out rehabilitation? How do you give hearing aids? How do you carry out cochlear implants for those who need it? And I think this is where we are having a big challenge, because the Ministry of Health, as you know, develops policy, but the county governments implement it. We have not had any county government so far that has mainstreamed ear and hearing care. We are hoping that, like I mentioned, I think in last week's presentation, is that the World Health Organization is moving a notch higher in terms of promoting ear and hearing care. And next year in March, the World Report on Hearing will be released. And this could be used as an advocacy tool to governments to mainstream ear and hearing care. So our major issue here in this country is that as we develop neonatal screening, you can't screen if you're not going to offer service. Because if a mother comes and you tell them, yes, your child doesn't hear, then what? So the two must go together. The counties must allocate resources for ear and hearing care and rehabilitation. The current national plan for ear and hearing care is coming to an end. Now, the next plan, we are hoping that the county governments will be deeply involved in developing that plan so that they can commit themselves to mainstreaming ear and hearing care. I think that's what I can say about a policy of making sure that we have neonatal screening. Thank you.
Thank you very much, Professor Macharia, for your input. There's Samuel Nyaga has something to share. What he says is that he had a patient 2 years old with tonsillar hypertrophy, and it was very concerning that both parents were deaf without any speech. But more interesting, the housemaid was also deaf. Obviously, the child did not have speech development, but understood certain sign language. They said they preferred a housemaid similar to them so that they could communicate to her. Any comments?
I've come across such families, but that is never wise, because when the child grows up, when you bring up a child, you're not bringing up a child for yourself, but for all of society. You don't know where the child will end up. They could end up in South Africa, in Australia, anywhere in the world. They may be gifted in something which takes them around the world. So it's good for the child to be able to harness whatever is there in the world in terms even of language, communication, and skills. And when you do it that way, you actually diminish the potential of the child. Because just because the parents cannot talk, doesn't mean the child should not talk. And normally in such cases, what I would advise, normally I used to advise them is that, look, let the child go to school, let the child learn how to talk, get a maid who can talk. It's good for the child to learn sign language, communicate with the parents, but you don't bring up a child for yourself. You'll not be there when the child is an adult or an old person. You bring them up for all of society. So you want them to interact with society from an early age and communicate as effectively as possible if and when their own body allows that.
Thank you so much, Dr. Mbira. Looks like we have exhausted our questions, unless there's one that is burning. Sorry. Yeah, I think I'll hand over to the chair, or I mean, I'll hand over to the chairperson, Dr. Geoffrey Otumu, to carry us, to continue with
Thank you so much, Dr. Mwaringa, for moderating this. Well done. I think before I invite the next speaker, let me just add to what Professor Macharia said about the policy implementation at county level. being one of the senior managers at the Kisii County, I would say that one of the things that is hampering the mainstreaming of ear and hearing care is basically the resource allocation to work plans, and also getting champions, say ear specialists who can then be able to continuously follow. But I think things should get better as we move on, with counties beginning to appreciate work plans and the resource allocations. So I guess as we get involved in the next work plans, we should be able to do better. I think in the interest of time, I now want to take this opportunity to invite the Microlabs representative, Plapu. Microlabs is basically the sponsor of this CME tonight, and they are the distributors of Erostin, Lecobact, and the Bandotab. We want to give them this opportunity for about 5 to 10 minutes to just quickly give their presentation, then we will end the session. Welcome, Prabhu.
Thank you, Dr. Joyfree Utumu. Thank you, the speaker, the moderator, Professor Isaac Macharia, Dr. Dean, and others. On behalf of Microlabs, I request my colleague, Ms. Efikan Osaya, to give a small corporate presentation. Ms. Efikans, please unmute your mic. Carry on.
Okay. Thank you, Mr. Prabhu. I'm going to share with you an overview of our corporate image. And in Microlabs, we protect life with quality and effective medicine at an affordable price. And that's where our commitment continues to bring joy to life. We have 14 world-class manufacturing facilities, and all our plants units are approved by the world leading bodies, that is US FDA, UK MHRA, WHO, and PPB Kenya. We have our global footprints present in 70 countries, spanning in Asia, Africa, USA, Europe, as well as in Middle East. What makes Microlabs stand out is that we have our own manufacturing and our own marketing and regulatory body, which sets us apart as a world-class from other pharmaceutical companies. Our major brand, which has made this webinar to be successful and has proven its effectiveness and is well known by doctors across Kenya, especially the ENTs, to rethink in allergic rhinitis, is Erostin. Erostin is our brand of Avastin, available in tablets of 10 milligrams and 20 milligrams, as well as syrup for the children, available in orange sweet flavor. The benefit of Erostin is that it has a rapid onset of action compared to cetirizine and loratadine. The onset of action is after 30 minutes, and that of cetirizine is 3 hours, and loratadine is 4 hours. And when it comes to the duration of action, these are very important parameters. With Erostin, can goes up to 32 hours, and while cetirizine and loratadine is 18 to 14 hours. This is important because when maybe a patient forgets to take the medicine, the drug is still available in the system. And also when it comes to sedation effect, the percentage of Erostin is 2% and below, compared to cetirizine as well as loratadine is 38 and 18% respectively. With Erostin, for your active patients, this will benefit them so that they can remain active. So doctor, kindly rethink on in allergic rhinitis with Erostin, 20 milligrams, 10 mg, as well as syrup for children. In the journal, speed matters. So does in infection management, dose matters with Levobac 750. As an ENT, in acute bacterial sinusitis, prescribe Levobac 750 OD for 5 to 10 days. And also in cases of nosocomial pneumonia, community-acquired pneumonia, complicated skin and skin structures infection, as well as in complicated urinary tract infection, prescribe Levobac 750 OD for 5 to 10 days, depending on the severity. And also in cases of laryngopharyngeal reflux disease, we have Pantotab, our brand of pantoprazole 40 milligrams, OD for 14 to 30 days. And also in cases of gastritis, duodenal ulcers, gastritis ulcers, as well as NSAID-induced ulcers. And in conclusion, as microlabs, our vision is to be regarded as states of the art pharmaceutical company in terms of quality and customer satisfaction. And our mission is to provide quality at a competitive price everywhere in the world. And that